So, Dr. Carolyn Trapp, great to be speaking with you. How are you doing?
Thanks, Ian. I'm doing great. Happy to be here.
Great. I got the mailings in the emails from Dr. Ted Barnett about your presentation that you're going to be giving tonight at Rochester Lifestyle Medicine. And so from Macedonia to the Navajo Nation, treating a worldwide diabetes epidemic with plant-based nutrition. I love it. And I definitely want to get into that in a second. I want to start with, give me some background on your experience with diabetes over the years.
Sure. So I am a nurse practitioner, and I have been working in primary care for many, many years and doing my best to help people with diabetes get the best medical care possible, right? And when I became a nurse practitioner, I'd been a diabetes educator for a number of years before that. When I became a nurse practitioner and I got that prescription pad and I could start writing prescriptions, I thought, now I can really make a difference for people who have diabetes, because this is a disease that causes all kinds of potential problems from head to toe: stroke, heart disease, kidney failure, nerve damage, blindness. And it was my understanding that if we just treat it aggressively, get people on medication sooner, more than one medication if needed, on insulin when needed, then we could prevent those complications. And my background's in nursing. I know how to teach people how to give an injection. So I thought, now I'll really do something meaningful. And in the medical practice I'm part of, we use these medications really aggressively. And we got good numbers. Our average A1C was close to the normal range. And so people monitoring their blood sugar at home saw good numbers. But, I learned a lot from my patients. They weren't all that appreciative of these good numbers. And the reason was because all these medications, and especially insulin, can cause low blood sugar. It can cause weight gain. It's expensive. So I started to rethink, maybe this isn't the best way to help people. And I was really lucky to learn about the work of Dr. Neal Barnard, and he was doing studies with a plant-based diet for people who have type 2 diabetes. And he had found that compared to a conventional diet for diabetes, a diet where people were told they needed to weigh and measure and do portion control and limit carbohydrates, and if they were overweight, they needed to eat 500 less calories every day. When that diet was compared to a low-fat plant-based diet, the people in the plant-based diet lost twice as much weight. Their hemoglobin A1C, which is a measure of diabetes control, came down 3 times as much. Their cholesterol got better, their kidney function got better. So Dr. Barnard had some experience working with people with diabetes, and I was lucky to find out about this early. This was before it had even been published, but I knew of the work he was doing, and I started trying it with my own patients. And initially it was sort of tentative.
I was going to say, were you skeptical?
Absolutely. And, I'll admit, the medical practice I'm part of, we had a dietitian years earlier who was vegan. And I thought, what she does is not possible for me. It's not possible for my patients. I just didn't, at the time, that just didn't seem like it was realistic, or who knew that it was even beneficial. I didn't know of other clinicians who were prescribing this. And my epiphany came around 2005, I think, where I had some health concerns of my own. My cholesterol was high. I was told I needed medication. I was told I would need that medication for the rest of my life. And, if I had been able to take a statin drug and lower my cholesterol and it worked, that probably would be, I would not be here today doing this interview with you. But I couldn't tolerate the one that my doctor prescribed for me. So we tried another, and then we tried a third, and they all made me sick. And that's when I started to think, well, I am a diabetes educator and a nurse practitioner, and lifestyle is a large part of these metabolic conditions that my patients are suffering from. So I should be able to find a dietary approach that works for this, right? So I had learned about plant-based nutrition myself. In fact, sort of ironic, I was at a conference for nurse practitioners, not on anything related to diet, and I met a colleague who told me about the Physicians Committee for Responsible Medicine, and I realized I had a book by Dr. Barnard at home on my shelf that I hadn't read. So anyway, that was sort of my introduction into this. So I had been doing it for myself, and I started to share it with my patients, and I saw some really interesting results. And one of the most dramatic was a gentleman who was in his early 40s, and he was a high school teacher, quite overweight, and his diabetes was uncontrolled. He had some other health problems, and he'd been told by his doctor that the 3 pills he was on for his diabetes were no longer working enough. He needed insulin. So the doctor sent him to see me. And he was, a challenge for him was that he was afraid of needles. He'd been hospitalized as a child, and for him, the thought of injecting insulin was terrifying. And it was everything he could do to prick his finger every now and then to check his blood sugar. So I said to him, well, there's a choice. We could do insulin, or your blood sugar's been high for a while now. Another week or 2 or 3 probably won't make a difference. Do you want to try eating a little differently? So we talked about a plant-based diet. I had materials from the Physicians Committee for Responsible Medicine. I shared that, and he embraced it. He and his wife got on board. They changed the way they were cooking, and the weight started to come off. And he ended up losing about 40 pounds over the next few months, and did not need to go on insulin, and had a drop in his A1C, which is a measure of diabetes control, and a normal is between 4 and 6%, and good control is usually considered 7% or lower. For most people, that's a reasonable goal. He was up over 9%. But within a few months of a plant-based diet, his blood sugars dropped. And, that certainly got my attention as to what's possible, and it got the attention of the physicians I work with. So that was kind of the beginning. And I'd had other patients who were doing those sorts of things as well. I had one young man who was obese and needed to have surgery for sleep apnea. And he had tried everything to lose weight, but nobody had ever talked to him about a plant-based diet. And I made that suggestion to him, changed his diet. He lost 30 pounds, didn't need to have the surgery. I had another man early on who I remember was being treated for depression, high blood pressure, diabetes. He changed to a plant-based diet, no longer needed medications for any of those conditions. He found with the weight loss, he had more energy, started moving more. When he was moving more, that probably helped the depression, didn't need medications. And I remember one of the doctors I work with saying to me, I can't get my patients to go for a walk. You're asking them to give up hamburger? They're not going to do that. Yeah. But I've come to think that everybody should have the choice. Everybody may not embrace this. Everybody may not embrace it at the time I suggest it, but I found that sometimes planting those seeds, you never know where they'll grow. And down the road, people come back to me and say, are you still talking about that plant-based diet? I'd like to know more about it. So it's definitely been life-changing for me and for those patients.
When you first started out prescribing this to patients, how prepared did you feel? How comfortable did you feel with it saying to my patients, hey, adopt a plant-based diet? Were you nervous? Were you apprehensive?
Oh, I was definitely nervous. I was nervous, first of all, what would they think of me? Because, their other healthcare professionals weren't talking about this. And was I some hippie who was not following the evidence about what worked, but doing something that was alternative or something that wasn't tested. So I was a little concerned about that. And I was also concerned about if this does work, what about the medications they're on? How do I manage those? If I have somebody, for example, the high school teacher I mentioned, he was on sometimes 200 units of insulin a day. And as he started to change his diet, he takes short-acting insulin at each meal, he takes a long-acting insulin at bedtime. Where do you start? And so and there are no guidelines. We have lots of published guidelines about how to start insulin and how to advance it, but nobody has written about how do you take people off of it. So it was really trial and error, and I was very open with my patients that we're going to figure this out together. And of course, there's a risk when you're prescribing medication. So deprescribing or taking them off, couldn't be any riskier. And actually the bigger concern is low blood sugar.
Right.
So, that's one of the leading causes of people, especially older people, ending up in the emergency room. So I was happy to help people get off their medication.
So you certainly had to put on your critical thinking hat as you were kind of developing these new protocols and taking people off these medications, for sure. Give us an idea of what the current paradigm is for treating diabetes. What's the standard of care for treating type 2 diabetes if a patient walks into their doctor's office and it's the first time they hear from their doctor, you're diagnosed with type 2 diabetes? What's the timeline look like?
Sure. So the paradigm for somebody who's newly diagnosed is they are encouraged to make lifestyle changes. And often they're told to be more active, and they're told maybe to be careful with their diet. Often patients come to me, they've been told to limit carbohydrates. They've been told to avoid sugar. And people will come in and say, I'm not eating bread, I'm not eating pasta. And for some that helps right away, but others it doesn't go far enough. So they are, a well-meaning doctor will mention lifestyle and medicine, but the guidelines also say that we should start people on a pill called metformin at diagnosis. And it wasn't always that way, but in recent years that was added. And then we continue to follow blood sugars, and if there hasn't been an improvement in the next 3 months or so, we can add a second medication. There are currently 12 classes of drugs for diabetes. There were 2 when I got into this, which is a few years ago. But now it's gotten really complicated. And within each of those classes, there's a number of choices. And the American Diabetes Association publishes an algorithm that says start with metformin, and then here are your choices if that doesn't work, and you can use this medication or this medication, this one. And then 3 to 6 months later, if there's not improvement, we can add a third medication. And at any point along here, if the numbers are high enough, we're encouraged to go to insulin. Now, to their credit, the American Diabetes Association has always said in the fine print, encourage lifestyle. But it's not front and center.
Right, fine print, keyword.
Right. And in the last year, in 2018, when they published their guidelines and the new algorithm, they have now, at each of those levels where we're supposed to add a second medication, it now says in bigger letters, encourage healthy diet and exercise, encourage lifestyle. So it's there. But at the same time, the ADA does not provide much guidance in terms of diet. And their position is there is no one best diet for people who have diabetes.
Do you agree with that?
You know what? I don't.
Okay, let's talk about it.
Okay.
So what I guess what issues do you have with the ADA? Because I did print out some literature actually from the ADA. Maybe we'll get to a few topics, but what issues or concerns do you have with the recommendations that the ADA has based on the published literature, I'm assuming?
Sure.
And then what recommendations do you make to your patients based on the results you've seen?
Sure. So, I like to follow rules when they make sense and there's evidence behind them, but my clinical experience has been so opposite what I've seen from these guidelines. And to say that there's no one best diet, and to say we should be saying to people, how do you what diet do you want to follow, or what changes do you want to make? I'm all about individualizing it, but I also feel strongly that we should let people know that there's this option that's really effective, and then they can make a choice. Because the challenge shouldn't be, because just like my experience was with this dietitian who worked in our office and who was vegan, and I thought I could never do that. Nobody had really told me about how doable it is and how to do it. And if I had known all of that, then I could have made a knowledgeable choice about how to treat my high cholesterol. But in terms of those guidelines, we know from the work of Dr. Dean Ornish and Dr. Caldwell Esselstyn that a plant-based diet can reverse heart disease. It's the only diet that's been proven to do that. Well, the leading cause of death for people who have diabetes, it's not high blood sugar, it's heart disease. And it's other vascular complications. So big blood vessels that go to the heart or the brain can lead to heart attack or stroke. Smaller blood vessels that go to the kidneys, eyes, nerves. If a plant-based diet has been proven to treat that vascular disease, why shouldn't it be the default diet for people who have type 2 diabetes? So, and even type 1 diabetes can benefit from it, because people with type 1 are at risk of vascular disease as well. So I like to say that I am within the ADA guidelines, because they do they do include a line within their clinical practice guidelines, and they've done that every year. Now, in 2009 was the first year they included a vegan or vegetarian diet. And the way they included it was they said it's a safe approach. So not the most enthusiastic endorsement, but it's safe for people who want to do it. And we have a lot of clinicians who will, if their patient wants to follow a vegan or vegetarian diet, or they're already doing it, then now the ADA says it's safe, so they can continue it. Clinician will say, you can continue. Well, in 2010, the ADA sort of upgraded their advice and said a plant-based diet is effective for weight loss and glycemic control. So that's great. But it's one line in a document that's, 120 pages. And you have to be looking for it, right? Yikes. So a lot of clinicians don't even know that this is an option, which is really too bad.
And so along with your presentations, the type of presentations you're giving tonight, I'm assuming that this is geared more towards the lay person, but you also educate medical professionals on this, correct?
I do. One of the joys of my job working for the Physicians Committee, I still see patients one day a week. I'm still part of an internal medicine practice in Michigan. But 11 years ago, I was invited to join the staff at the Physicians Committee, and I'm the director of diabetes education and care. So one of my responsibilities is to provide education to clinicians. So I speak at a fair number of conferences, and I've authored and co-authored some papers, and I teach every year at schools of nursing in Michigan, and it's my joy to bring this information to clinicians. And it's getting easier and easier, because now the word is getting out.
Right.
I mean, people know the word vegan, first of all. We also have the word plant-based, which I think is still kind of hard to say, but that seems to be a more acceptable word to a lot of people. And research is using that. The USDA says a plant-based diet is a good nutrition approach. So That word's becoming more available. And every chance I get, I'm happy to talk to my colleagues.
What have been some of the major concerns? Like, I've given a few presentations here in Rochester at public libraries, speaking to people about plant-based nutrition in general and what it can do to prevent and reverse chronic diseases. And I always get people, I'm sure you do, after the presentation's over, they come up to you and say, great presentation, I'd like to ask you a question. I'm sure you get questions or let's call them concerns from medical professionals saying, I love what you're talking about, but I have this concern, or I don't feel this would work with my patient population because of X, Y, and Z. What are some of the most common things you hear in case a medical professional is listening to this conversation?
Well, one concern is around cost. There's a perception that a plant-based diet is expensive. And when you look at what the cost of medications are, that issue goes right out the window, I think. Insulin now, a month's supply of insulin can be $400, $500, $600 plus the little needles that go with it. So these medications, and not everybody has insurance that covers the total cost or even part of the cost anymore. So cost is one concern. Ability or skills or willingness is another concern, and that's probably one of the biggest. Certainly if a healthcare professional is not following a plant-based diet himself or herself, then they may not know how doable it is. And I really encourage clinicians to try it out. Unlike the conventional diabetes diet where you had to do portion control and, you had to figure out, one time it was exchanges. You could have this much of this or this much of that. Now we talk more about counting carbohydrates and limiting foods from certain groups. Plant-based diet's so easy. You focus on these 4 food groups: fruits, vegetables, beans, whole grains, and maybe a handful of nuts or some flaxseed. And you can eat them in any combination you want, and there's lots of ways to cook them, and you can get your beans out of cans. I mean, learning these basic skills is a great way to be able to help your patients figure it out. Mm-hmm. So conveniences would be another concern. Another concern that people bring up, and this is clinicians, but also patients, is, well, I'm going to do this, but what about the rest of my family? My spouse would never go along with this. And I have to say, that was a concern for me in my house. I didn't grow up eating plant-based. My extended family wasn't. My husband had no need to make a diet change. He's an athlete. He's, in good health. So was I going to inflict this crazy diet on everybody else? But people have come along. Part of it was learning some new skills, finding the cookbooks I liked, and I love Colleen Patrick Goudreau's expression of the joyful vegan, and that's certainly what I aspire to be. If we can cook for others and bring them in, show them the food tastes great, that it's affordable, that it can be quick and easy, that's a great way to bring people along.
Let's pivot and talk about your presentation tonight. And I what I say to my guests who have written books or who are giving presentations is I say, let's not give away everything in the book or the presentation.
Sure.
Make this almost a commercial and to sell your presentation, because I want more and more people to listen to it. But again, it's from Macedonia to the Navajo Nation, treating a worldwide diabetes epidemic with plant-based nutrition. What are some of the takeaways and some of the main points that you are going to talk about tonight, and maybe talk about what you found around the world?
Sure. So this is going to be a travelogue tonight. I have had this tremendous privilege through my work to do some travel and to see diabetes on different parts of the planet. And I've seen really good and I've seen really bad. And I will share stories from my trip to China. I was part of a delegation of healthcare professionals, diabetes educators that went to China China has a huge epidemic of diabetes. They're very worried about this, and we went to provide some education and to learn. And I have some wonderful pictures, and we'll talk about why is this a problem. Some people think maybe it's because of all the rice people are eating in China, but they've existed on rice, forever, and diabetes is a much more recent problem. So we'll talk about why that is. I've also had the privilege of traveling to the Republic of Macedonia, and which Macedonia is just north of Greece, not far from the Mediterranean, although it's landlocked. In Macedonia, they're also very concerned about a diabetes epidemic, and we'll talk about why. But one of the really interesting things about my trip there was I was there on the invitation of the Minister of Health, and they were concerned about the cost of insulin. It's common practice there to put people on insulin who have type 2 diabetes, even before using some other pills that might work, and they can't afford the expense. So we'll talk about why they have that problem and why insulin use is so widespread there. And I'll give you a hint: it's not necessarily standard of care; it's more about industry influence. But the travel that has had the biggest impact on me is my experience working with Native Americans. And well, let's see, where do I even start? This is just, it's been such a incredible learning opportunity for me, and a wonderful, well, I'm just really grateful to the Native Americans I've met and who have taken me under their wing and taught me about culture, and have been talked about what the traditional diet was of many tribes. And I'm referring mostly to the Navajo people. The Navajo tribe is one of the largest tribes. There's a little bit of debate if they're number one or number two, but the Navajo Nation covers parts of Arizona, New Mexico, and Utah. 300,000 people, and the rates of diabetes are sky high. It's been estimated that 16% of adults have type 2 diabetes, and it's probably even higher, though, because many of the census doesn't work well in these really remote areas. And why have they been so hard hit? Well, sometimes people think it's because of alcoholism or depression or genes, that this is a genetic problem. But we can trace the roots of diabetes among the Navajo and other tribes in the Southwest and elsewhere to the time in history where they were forcibly removed from their land, and their ability to grow food and hunt for food was lost. Water has been dammed, their agriculture practices have been changed, and the U.S. government started providing these commodity foods, and they weren't the healthiest foods, and they certainly weren't things that were traditionally part of their diet. So we've seen these high rates of diabetes, and I equate it really to the smallpox blankets, that it's one more attempt, intentional or not, to wipe out an entire people, because what we see are huge rates of diabetes, overweight issues, cancers that are related to diet, colon cancer, stomach cancer, and all of these are food related. So what's inspiring, it sounds depressing, but it's actually, I think, a happy and hopeful story, because I've seen that when people get away from highly processed foods and get away from all of the canned meat and the cheese. Cheese is big on the Navajo Nation. It's sometimes called Navajo gold. And it's a little addictive, right? Yeah. And people unfortunately often love their cheese. And when they make change and they're willing to set those foods aside and fill up on whole grains and beans and fruits and vegetables, they get better.
Right.
And anyway, I've got great stories and great pictures that tell these stories. And I think the takeaway for the people of Rochester and people everywhere is that, if you think that changing to a plant-based diet is too hard, when I consider the Navajo people that I've worked with who live far, far from a grocery store, have limited resources. Some don't have running water or electricity, and they're able to eat plant-based. What excuse do we have when we've got, the local grocery store that's got beautiful fresh produce that's affordable all the time? So it'll be a fun presentation tonight, and a great way to learn and to feel hopeful that diabetes can definitely be turned around. As one of my friends, Donna Hall, says, she's from a tribe in Minnesota, she says, I don't want my children and grandchildren to even know the word diabetes. And coming from a place where, as she said, if I'm in a room with 5 people, 3 of them have it, to talk about the next generation not having it is really inspirational.
Yeah. Something you said that sparked the next question is you said that the U.S. government provides these food commodities to the Navajo Nation and these tribes, and I know the work of Dr. Neal Barnard, where he, of the doctors and scholars in this movement, I feel that he is known for doing things and affecting change from the top. Meaning, I know that he does a lot of work, and he and PCRM do a lot of work with trying to change legislation and trying to, govern change from the top down. Someone might say that, make the argument that what you're doing, although noble, is you are kind of addressing things downstream, and that your efforts would be better, more effective if we could go upstream and notify someone, whoever's in charge on a governmental level, like, hey, what you're doing, you may think it's helping by providing them food, but it's really, in the end, it's not. It's only causing this increase in type 2 diabetes. Is that something that you or Neal Barnard have tried to address? Oh,
that is a great question, Ian. So we are aware that it's not just about individual choices, certainly, to solve this problem, that we can maybe reach a small number of people, but absolutely for people to continue to get a box every month from it's called the Federal Distribution Food Program on Indian Reservations. They get a box with, it's got some fruits and vegetables in it, but it's got canned meat and it's got cheese in it. How do we make that change? And I'll tell you, I've tried a couple different things. There are Indian Health Services on the Navajo Reservation, right? Navajo Nation. And so I've gotten to know some people who work for IHS, and their hands are kind of tied around some issues around what they're teaching, what nutrition education materials they're using. So I thought, well, I'll just go up the chain of command, right? And I'm going back a number of years, but I called Indian Health Service and talked to the director of nutrition, and I explained, I work with Dr. Neal Barnard. He's written a book. It's been on national public TV. I'm out on the Navajo Nation. People are interested in it. And she told me Native Americans won't give up meat. And we talked a little bit more, and I said, I'd love to just share more information about this with you, and because I'd love to see some of our nutrition materials be available to Indian Health Service. She hung up on me.
Wow.
So, and I don't know her name, and I understand she's no longer with them. But so that's on a government agency level. There's some resistance.
Yeah.
There has been. I don't know if that's still true, and I want to try again. But let me give you another example of where I think there's potential. in that commodities box, up until about 10 years ago, lard was included in the box. And pure fat, right? Why would we be including that? But as you said, some well-meaning bureaucrat probably figured, we've got excesses of this, right, from pork production. Let's pass it on. So anyway, somebody somewhere made the decision to get lard out of that box. So my thinking is not that we need to go to the government and make that change. I mean, I'd love to make that happen. And the Physicians Committee is working on that. We are currently working on efforts to help shape the next dietary guidelines. In fact, until March 30th, there is a comment period. You can go to the Dietary Guidelines website, and you can type in your comment about how you think the guidelines need to change. What should they include? So I encourage people to do that because this is, in 2015 was the first year they came out and said a plant-based diet is a dietary pattern is one of 3 patterns that would be healthy for all Americans. So anyway, if lard can be taken away, removed from that list, we now want to I've set my sight on cheese. Let's get rid of that, right? So, but what would happen if this product that's currently being referred to as Navajo Gold was suddenly removed? There might be some Navajo people that would be really upset by that. And I think that we need to do a 2-prong approach. We need to create a campaign where the Navajo people are educated about this being a problem food, and then they reject it, and they go to their elected officials and say, we don't want to have this included anymore. And those elected officials are the ones who have the power to control what's in those boxes.
Right. But I've heard, and I'm not an expert on this, but I've heard that there is, again, a lot of, if your constituents are, if your constituents live in a very rural area and there's a lot of dairy farms, you're going to be a lot less likely to enact legislation that says reduce the amount of, enact legislation that says reduce the amount of dairy that we're eating as a nation, and that has to do with, subsidies and stuff like that. So that's another issue that we have to tackle.
Yeah. Well, nobody's producing cheese on the Navajo Nation. It's all imported. And we also have such an epidemic of disease that it's not really that hard to sell. I think education can make a big difference. And we have to replace it with something else. We're taking away, we're suggesting don't eat cheese, but we're saying fill up on these other foods.
Right. Let me just, sorry for those of you listening to the paper crinkles here, but I have a few questions. This is coming straight from the American Diabetes Association website, and this is under their myths section. And what is your thoughts on, you see some special diabetic food out there like Glucerna. What are your thoughts on eating that for people with type 2 diabetes?
Well, I'm curious what you found on the ADA website, if it was a pop-up ad or an ad included for those products, or if it was that those are recommended or...
Well, no, this is under their myths section, diabetes myths. So what it says is people with diabetes should eat diabetic food. So it says myth. People with diabetes should eat special diabetic foods. True or false? What's your position on that?
Yeah, so I would say that it's false. Nobody needs to have a product that's labeled, this is for diabetes. Unfortunately, the foods that are the best for people with diabetes don't come with labels. Our produce, our beans, our whole grains. When I was in China, our delegation was invited to attend a program that was for lay people, and they probably had 400 or 500 people there and who came to learn about diabetes. And it was sponsored by a sugar-free cookie company.
Yikes.
In China, where cookies traditionally were not a big deal, right? So that just shows you how pervasive that is. So yeah, there's definitely industries looking to make a profit, but have you ever tasted any of those products?
No.
What a way to feel miserable about having a disease is not only, you have to take all these medications, you have to prick your finger all the time, you have to worry about low blood sugar, you have to worry about getting complications, but you also, you can't enjoy a I don't know, normal cookie, or you have to have all of these other products. And I definitely don't use them. In fact, here, I will say this on the record. Reps are always dropping off cans of those liquid nutrient formulas. I won't say their name. They're dropping them off for me to give to my patients, and I have no use for them.
Straight in the garbage.
Absolutely not willing to share them.
Good for you. How about this is, let's see, myth. If you have type 2 diabetes and your doctor says you need to start using insulin, it means you're failing to take care of your diabetes properly. And it says underneath that, fact. For most people, type 2 diabetes is a progressive disease. What do you think about that? It wasn't the myth, it was the fact. That's
Right.
that last statement that kind of I highlighted and I said, I want to see what Carolyn says about this.
I started this interview by saying it was one of the things I was taught, that most people are going to need insulin, that we're treating it well when we put people on medication because it's a progressive disease. And I was taught to teach people it's not your fault if you need medication. You could do everything right, but it's a progressive disease. You know what? Now I think that is a party line. That is industry influence, because, my patient Ira I mentioned earlier, who was on over 200 units of insulin a day for more than 10 years.
Wow.
And I was taught that at the time of diagnosis, that the pancreas is not able to keep up with the need for insulin, and that actually, let me say that differently. At diagnosis, people are resistant to insulin. So you're making lots of insulin, but you can't keep up with demand. The pancreas is working pretty well at that point. The beta cells that are making insulin doing fine. But with this insulin resistance that continues, the pancreas over time can't keep up with that demand. And at 10 years, that's the time where there's this chart that it's, lots of medical conferences where I've been taught where, people are teaching about the natural history of diabetes. They show this chart, and it shows at about the 10-year point, diagnosis, ability to produce insulin in type 2 diabetes way down, and many people will need insulin. So explain to me, how can somebody be on insulin for a long period of time and then change their diet and not need it anymore if it's a progressive disease?
Right.
It's a great example of how resilient the human body is. And we thought that these beta cells could not regenerate, but I don't think that that's true.
So 100% false. Most people with type 2 diabetes is a progressive disease. False. False from your perspective.
Well, I can't say 100% because there are people who, despite, I think, really valiant efforts to do a really healthful plant-based diet, avoid oil, there are some people who will still have elevated blood sugar, and they may need some medication to control that, especially if it's causing some symptoms. But you know what? I'm not really sure they have true type 2 diabetes, because for a long time we've classified type 1, type 2. But now, and this is within the guidelines, there are some variations. And we have what some people call type 1.5. So there are some people who are still making some insulin, but it might not be enough. But with a diet change, they may not need as much insulin. Right. So many of those people will benefit.
A couple follow-ups. So the gym teacher you said who was taking 200 units of insulin a day, what did he eventually get down to?
So he was a history teacher. And high school history teacher. He's on no insulin.
Great. That's amazing. And the second follow-up was, I had this on my list here of questions, is there a point of no return? Like, this history teacher, you said 10 years taking insulin, was able to get off it completely by changing his diet. Have you noticed at about, let's say arbitrarily, the 15-year mark or the 20-year mark, or if the literature shows that at the 20-year mark, a significantly a greater percentage of people who are taking insulin have to keep taking it for the rest of their lives?
The answer to that is I really don't know.
Yeah.
We don't have studies of people who've had diabetes for 15, 20 years on insulin. In the study that Dr. Barnard's group did that was published in 2006 in Diabetes Care, which is the journal of the American Diabetes Association, they found the average, the people who were on insulin in that study had diabetes for an average of 8 years. And 44% of people in the plant-based group were able to reduce or eliminate medication. So not everybody, but they did twice as well as people who were following a conventional diet. So, as I said, I think that medication reduction is definitely one benefit, but it's not the only benefit, right? And I know listeners of your podcast come to a plant-based diet for a number of different reasons, health reasons. So not everybody will be able to eliminate medication, and I certainly don't want to oversell this. And my experience, though, has been that many, many, many will be able to, if not eliminate it, definitely reduce it.
Mm-hmm. How about this? It says, myth. Fruit is a healthy food. Therefore, it's okay to eat as much of it as you wish. So that's the myth.
Right.
And if I can just get through, fruit it says, so fact. Fruit is a healthy food. It contains fiber and lots of vitamins and minerals. Because fruits contain carbohydrates, they do raise blood glucose and need to be included in your meal plan. Talk to your dietitian about the amount, frequency, and types of fruits you should eat. What's your position on fruit?
So I like fruit.
Me too.
So that statement, the fact, is true for people who are eating a diet that includes meat. If you are ingesting foods that have a lot of fat in them, that fat gets inside muscle cells and it interferes with insulin's ability to do its job. But when people shift to a plant-based diet, that fat inside muscle cells goes away for many people, and now insulin can work. And if your insulin is doing its job, then you can enjoy a piece of fruit and digest it. It'll be metabolized appropriately, and it will not spike blood sugars above where they should be. And I love that the ADA says that fruits are full of all these beneficial nutrients. In fact, it's been shown that people who have there's a higher mortality risk if you don't eat enough fruits and vegetables. So fruits are definitely really important to include, and I'm pleased that the ADA is adding them. But it's definitely an option for people who adopt a plant-based diet. Often they can enjoy fruit and they don't have to measure and weigh. Not measure and weigh, but they don't have to limit the amount of fruit they're eating. Now, that said, there's always some exceptions.
Sure.
And I have some patients who've said, I notice when I eat a lot of fruit, my blood sugar goes too high. But I would suggest, even in that situation, like, what's too high? If your blood sugar is going up 180, 200 and staying high, that is a problem, right? But we've been trained to think that, blood sugar is the most important thing. It should always be in the normal range and it can never go up. But we also now know that blood sugar is just one measure of health, but blood cholesterol and blood pressure are probably more important in terms of longevity and in terms of disease prevention. Blood sugar has a much smaller role. And we focus on it because we can. It's easy to prick your finger and get a number and stress out about it and try and address it through whatever, medication or what we're eating. But if we're trying to reduce cholesterol, if we're trying to lower blood pressure, those are certainly related to diet as well. And we have excellent evidence that meat raises cholesterol and raises blood pressure. So if we can get people focused on that and move the focus away from carbohydrates, and when we do talk about carbohydrates, we have to make the distinction. Healthy carbs, not healthy carbs.
What is that distinction?
Sure. So healthy carb are, as my Native American friends like to say, the foods that come from Mother Earth, the things that grow in the ground, things that don't come in a shiny package. The unhealthy carbohydrates are things that come out of a factory, and they're highly processed and they have no fiber. So things that have white sugar and white flour. Those are the carbohydrates that absolutely we want to be careful with. They don't have nutritional benefit.
Right. What I say to people is you got to understand the difference between pizza carbs and sweet potato carbs.
That's great. Perfect.
So I want to close this interview with some practical advice for people out there who may be pre-diabetic or diabetic or know someone who is. I'm surprised we didn't cover this at the very beginning about sort of the etiology behind type 2 diabetes and this insulin resistance, about how people think it's carbs, carbs, carbs. When I say to people, I eat 80% of the calories that I eat in a day, 70 to 80, are coming from carbs. So why am I not a type 2 diabetic, raging type 2 diabetic? So it's obviously not carbs. And you mentioned meat and insulin sensitivity. So maybe just explain a little bit about what causes the insulin sensitivity and some practical advice for people to implement into their lifestyle after they're done listening to lower their blood sugars or help those around them.
So if you have diabetes or you're worried about getting it, food can help or food can hurt. And the foods that can hurt are, I had talked about the highly processed things, but why is meat a concern? Why is anything that comes from an animal a concern? And there's a number of reasons. Food's a package, right? It's got a lot of things in it, and there's a lot of things that eating animal products can do. So one of those would be the fat content. And the only products that have cholesterol come from animals. Most of the saturated fat in our diet comes from animal products. And the concern... I'm sorry, can we just stop for a minute?
Absolutely.
I got to get a drink.
Absolutely.
Let's just do that, take over.
Okay, no problem.
There were so many directions I wanted to go. I couldn't decide where to go first.
That's fine.
Okay. So you asked, somebody's diagnosed with diabetes or they're afraid of getting diabetes, what should they do first?
Yeah.
And what can they do to turn this around? Well, what they're eating can make a huge difference. And we know that the standard American diet, the SAD diet, is problematic for a number of reasons. One is all the processed foods and just not things that are highly processed. White flour, white sugar don't have any nutritional benefit. So we're getting all these empty calories. That puts on weight. The more you weigh, the more insulin your body needs to produce. So avoiding those foods that don't have benefits are a good place to start. Another concern specific to meat is the type of iron that's in meat. And, there are two different kinds of iron. There's heme iron and non-heme iron. And meat contains heme iron. Well, why is that a problem? Well, iron has been linked to insulin resistance. And if your insulin can't do its job, then blood sugars will go up and diabetes is down the road. Plants have non-heme iron, so we don't have to worry about not getting enough iron. We don't have to worry about developing anemia from eating plants. The beauty of non-heme iron is when there's too much of it in our body is able to get rid of it. But heme iron stays.
Really?
So that would be one more reason to eat less meat or get rid of it completely. Another concern is inflammation. And we know that that animal products, for a number of reasons, raise inflammation, cause an inflammatory response in our body that can promote insulin resistance. But one of the concerns that I think is maybe something that is the most confusing to people is around dietary fat. And we hear, eat eggs, don't eat eggs, right? That was a recommendation from the American Heart Association that has changed and, goes back and forth. And people throw up their hands and say, you don't know what you're talking about. I'm just going to eat whatever, right, because the experts don't seem to know. But there's there is clear evidence that the more saturated fat and cholesterol that's consumed, the more cholesterol goes up, the more risk of heart disease, the leading cause of death in people who have diabetes. And that when we eliminate those from the diet, that turns around a lot of problems. So we want to address this underlying problem, this process within our bodies that people who have a genetic predisposition will take excess dietary fat from meat and other sources and store it in muscle cells. And that is called intramyocellular lipid. And when that happens, that buildup of fat inside skeletal muscles limits the ability of insulin to do its job. But when people change to a plant-based diet, and this has been shown in research studies, scientists can actually look inside the muscle cells of people with insulin resistance or type 2 diabetes and see how that fat just disappears, and that insulin resistance improves. So lots of reasons. If you want to get real technical, there are a number of physiologic reasons to set aside animal products. And the beauty of that approach is that it can not just manage diabetes, because that's what us clinicians were always taught. It's a progressive disease. The best we can do is manage it. You can't cure it. But that's not been my clinical experience, and we can do more than manage it. We can treat this disease.
Something that is, and I know I said I would end it there, but what you say about saturated fat and cholesterol and meat and how it creates this insulin resistance, and that is the underlying cause of type 2 diabetes, that seems particularly at odds with the mentality of those eating a ketogenic diet. People, I think, gravitate towards the high protein, high fat, and maybe shades of paleo as well, because they say, wait a second, diabetes is caused by too much sugar. If I eliminate the sugar, I eliminate the diabetes. Ipso facto, I'm going to go with a ketogenic diet, which has no sugar, with, I say to people, I'm not trolling. I'm just sort of watching from the sidelines on some ketogenic Facebook groups. It is like rolly eyes emoji, cringeworthy recipes. If you were sitting in front of a group of quote unquote receptive, whether it be healthcare practitioners or lay people who were passionately keto, who were like, you know what, that makes sense, what would you say to them about their dietary choices and their lifestyle of ketogenic?
Yeah. Well, with any diet where you're restricting a food group, people will see weight loss.
Right.
And in the short term, that absolutely can seem to turn diabetes around. It doesn't get at the underlying problems, and we're not just trying to improve blood sugar. We're trying to prevent heart disease. And there's no long-term evidence that a ketogenic diet does that.
Got it. Simple answer. So, Dr. Carolyn Trapp, thank you very much. Thank you so much for your time. I really appreciate it. And I know, as I get older and older, I just turned 30, a couple months ago, but I know that time is the commodity that we're all seeking. So thank you very much for your time. And I know this will make a great final product.
Thank you, Ian. This was fun.
Thank you. If you enjoyed this conversation, please visit rochesterlifestylemedicine.com for information on future speakers in the Lifestyle as Medicine series, as well as previously published video interviews with past guests.